Thank you very much. And so, first of all, I'm going to talk about mechanical ventilation, meaning invasive mechanical ventilation. I realized that non-invasive ventilation is successful in most COPD decompensated patients. The failure rate is low. It's between 15 and 25%, probably closer to 15. In the last paper by Joliet on the American Journal of Respiratory Critical Care Medicine, the failure rate is 14 point something. So non-invasive ventilation is the mainstay of the ventilatory treatment in COPD. So which are the targets of mechanical ventilation in COPD patients? What do we have to cope with? We have to cope with hyperinflation, AutoPEEP, and PEEP to start with. They have three basic mechanisms. One is activation of the expiratory muscles, but that is not very important in mechanical ventilation. The other two types are, to put it simple, is when the expiratory time is too short. We have an increased resistance, and the lung does not have enough time to empty completely. So what happens here is that, you see, this is a normal lung, starts from FRC, inflation, deflation. It goes back to zero. But if resistance is high, the volume goes up, and then the flow is smaller because the pressure is the same, but the resistance is increased. So flow is smaller, takes more time, and it does not empty completely. So what happens is that now the volume of the lung is this one, and the next breath, instead of starting from zero, starts from here and goes 500 milliliters higher once again. And now, once again, does not have time to expire completely. So this, till the pressure goes so high that is enough to empty completely the lung, but at end expiration, the volume is not zero. It has increased of a certain amount, which is the hyperinflated volume. The end expiratory lung volume is higher than the expected FRC and is close to the maximum capacity of the lung. How can we measure that? By basically two observations. First of all, when the flow starts, here you see when the flow starts, the pressure has already raised higher than PEEP. You see this line? I can't see. You see this line? When the flow starts, the pressure has already gone up. This is the dynamic AutoPEEP. The air does not get into the lung unless the pressure is raised up to a certain point, because there is a pressure inside the lung already, which is AutoPEEP. You can measure AutoPEEP statically, and you can do that by making an end expiratory occlusion here. You push the button, you close the expiratory valve. At this point, the pressure in the airways equilibrates with the pressure in the alveoli. And as if you see that the pressure goes up stepwise, this is AutoPEEP, is the amount of pressure that has remained inside the lung because the patient did not have time to expire. So two ways: either you observe the step at which flow starts, or you make an occlusion. The two values are not the same, but you can use one of the two. Now, how can we decrease dynamic hyperinflation? The first method is really obvious. If you decrease the respiratory rate, you increase the expiratory time. And by increasing the expiratory time, you might reach a lower pressure. Moreover, you can play against the hyperinflation effects. And one is that you have to treat the hemodynamic impairment, if you have any. Here, this is a paper by Franco Laghi from Chicago. See here, the patient is in assist control with an end inspiratory pause. You see that you have inspiratory flow, a pause, expiration. Inspiratory flow, pause, expiration. First of all, you can notice that the flow does not reach zero. When inspiration starts, flow is not zero. It means that the lung is not empty yet. And this is the the lung volume. Now, Franco Laghi took the end inspiratory pause away. What he did, he increased the expiratory time. By increasing the expiratory time, now the flow is not zero, but is much closer to zero. And as you can see, the volume goes down. Dynamic hyperinflation is there again, but much smaller. So what did he do? He decreased the inspiratory time and increased the expiratory time. When you do that, you can check what happens to the hyperinflation by measuring AutoPEEP and by measuring plateau pressure. Keep an eye on that, particularly if you have increased a little bit tidal volume. The second or third mechanism of hyperinflation is airway collapse. The first mechanism was due to increased expiratory resistance, chronic bronchitis. This is probably more related to emphysema and lack of structural support for the bronchi. The bronchi stay open because the lung around them pulls the bronchi open. If the structure of the lung fails, during expiration, the bronchus will collapse. You can see it here. See, this is flow, and this is volume. Please keep in mind that volume and pressure are proportional. The higher the volume, the higher the pressure inside the lung. So normally the flow-volume relationship is straight, because the higher the volume, the higher the pressure, the higher the pressure, the higher the flow. But in COPD patient, you see that at a certain point, the flow stops, or the change in flow becomes much slower. Why? Because the bronchi collapse and the flow becomes much smaller than the flow you have with an open airway. You see on the flow volume curve, you see this shape that is far from straight. This is the sign of expiratory collapse of the airways. Now, which kind of PEEP should we use in mechanically ventilated COPD patients? Well, the choice of PEEP in COPD patients is very important during assisted ventilation. It's not so important during controlled mechanical ventilation, but is sure very important during assisted ventilation. Here you see the effect of external PEEP in COPD patient. This is a COPD patient. He has a certain amount of intrinsic PEEP, an amount of pressure that is generated by the tidal volume, plus the resistive expiratory pressure. The volume of the lung is hyperinflation plus tidal volume. Now, if we add PEEP, an external PEEP, if AutoPEEP is due to airway collapse, the external PEEP has no effect over PEEP-I. And hyperinflation does not increase. Here you see the change in lung volume, and this plot is the difference between external PEEP and PEEP-I. 0 means that the external PEEP equals PEEP-I. Suppose your patient has 5 of AutoPEEP. When you put 5 of external PEEP, the change in lung volume is very small. But when you go higher than AutoPEEP, then the volume goes up, obviously. Is this important? Yes, because when the patient has to inspire, he has to, first of all, make an effort to reach the PEEP level before he gets some air into the alveoli. So if I put a PEEP similar to AutoPEEP, chances are I decrease the work of breathing. When I do pressure support in COPD patient, I have to be very careful about synchronization. And a particularly dangerous phenomenon is when we use a pressure support too high. If we use a pressure support too high, the tidal volume will be too big for the mechanics of the patient. It means the patient will not have time to expire before he starts the next breath. Here, This is pressure support, and these patients makes an effort that starts the inspiratory flow. This tidal volume is probably too big for this patient. When he starts the next breath, he's not able to decrease the airway pressure enough to start the ventilator. So what we should do here is to decrease the amount of pressure support to decrease the tidal volume. There are many ways we can play to improve synchronization. We can play with trigger sensitivity, with the trigger to expiration, inspiratory flow ramp, but most of those are often taken care of if you use NAVA, that is neurally adapted ventilatory assist. If we drive the ventilator by the electromyographic signal of the diaphragm, we are assured most of the time of synchronization. It's not perfect, but it works better most of the time. Now, my last part refers to the fact that we ventilate these COPD patients in controlled mechanical ventilation. Which are the patients that we ventilate in controlled mechanical ventilation? Those that fail non-invasive ventilation. I told you at the start that the patients that fail non-invasive ventilation are not many, are between 15 and 25% of the hospitalized patients. The rest is successful with non-invasive ventilation. However, if you look here, you see that mortality at 6 months is 46.8%. So mortality of these patients is still very high. If your patient fails non-invasive ventilation and goes to mechanical ventilation, it has 50% chances of dying in these next 6 months. Now, as something is slowly creeping up, and is the use of CO2 removal in COPD. There is a lot of excitement about this. But this is still an experimental technique. People have been experimenting with extracorporeal CO2 removal at low flow to prevent intubation in decompensated COPD patient, or to proceed to early extubation. This is an example of one of those patients. You see here a few things. First of all, in the bottom triangles is AutoPEEP. When Dr. Cardenas removed CO2 extracorporeally, the first thing that happened is that AutoPEEP went down. And AutoPEEP went down because the patient decreased its own ventilation, since CO2 was removed by the extracorporeal lung. Now I want to call your attention to something different. What is this in green? This is the total CO2 production of the patient. When CO2 removal starts, the metabolism of the patient decreases from 130 milliliters per minute to less than 100. Why? Because his work was decreased. He was working to breathe. And he was spending 30% of his oxygen consumption just to breathe. Anyway, Dr. Ranieri and Del Sorbo applied extracorporeal CO2 removal in hypercapnic patients that were at risk of failing non-invasive ventilation. And they actually decreased the number of intubations. However, they had a lot of side effects, mainly related to anticoagulation. In this study done in Germany, in patients having failed non-invasive ventilation, extubation could be done much earlier. They could even prevent intubation in patients failing non-invasive ventilation. There is still a lot to do, but the basic idea is to reach a low flow system with a flow similar to dialysis, to remove CO2 from decompensated COPD patients and avoid mechanical ventilation. But the way to get there is still very long and is still totally experimental, even if we have big pressures from commercial companies. Thank you very much.